I think you may be on mute, Kathy. You may need to unmute.
Oh,
There you go.
no, okay. We want to welcome you tonight. It's a pleasure, an honor, and a joy to be here with you at this conference. And tonight I have to first start with acknowledgement that this PowerPoint has been put together by Karen, and it's my honor to join with her in sharing these signs and how to get help. So, shall we begin? We're going to cover tonight common mental health experiences of patients and families. We're going to go over warning signs and also finding help. Next slide. We find that, as people living with a connective tissue condition, that there are many feelings and thoughts and emotions and experiences, things that we experience with this, and from sadness and overwhelmingness to crying, to feelings of guilt or hopelessness, lost, or I'm often tired is our experience. I'm that and helplessness and confused with just all of the changes going on in our bodies and around us and in our family stuff. So, but these are very common. You'll see on our slide here, it says common. We want you to know that it's that you are part of the family with us, and we are all most of us at some time in our life will experience these feelings. The next slide, Karen. Common emotional responses impacting quality of life. Again, Karen and I wanted to really emphasize that these are normal. They're adaptive responses to the realities of life, of living with a connective tissue disorder or loving someone with a connective tissue disorder. Again, the sadness, depression, hopelessness, helplessness, anger, resentment, guilt, grief, fear, anxiety. I have to admit sometimes that sadness and anger seem like the two sides of a coin, um, as things pop up in life. But one of the key points that I were really on my heart as I was preparing for this was that you would know that you are not alone. You're not alone. You're not the only one that feels this way, that goes through these emotions and experiences. And you're not alone in walking through them and turning them into something beautiful, of a testimony of just your strength and your resilience and your compassion and your purpose. I may I tell you a quick story here, in that I'm one of five. My first brother died shortly after birth. That's when my mom first heard the word Marfan's. And so out of the four of us, the first three have Marfan's. And one day my sister said to my brother, "Don't you wish that you didn't have Marfan's?" And my brother said to her, "Why? So I could wear t-shirts?" Because my brother, we had that pectus, one of the symptoms was for us, and he had a protruding pectus. And it was like, why? I mean, this is who we are. This has been a part of the carving of our lives and our identity and our legacy, and just in our strength and our effect on the world has been these, whether it's meds or Marfan's or any other connective tissue. So I just want you to know you're not alone. There's people that have gone before you. There's people that are going to come after you, and you're going to get through these. And I'm thankful that Karen will be presenting lots and lots of good ideas. and lots of resources.
One thing that I always want to point out too is that these are not necessarily symptoms of mental health concerns or mental illness. These are normal human emotions, normal human experiences to an abnormal set of circumstances. And so having any one of these or having any number of these does not inherently mean that there is the presence of a mental health concern that would be what we would call like clinically significant. But regardless of whether it meets the threshold of clinical significance from a diagnostic perspective, these are still really impactful experiences that we all live with and hopefully find ways to cope with in more effective ways. So with that, one of the things that I want to really emphasize tonight is that when we're distinguishing between normal human emotions and mental health concerns, we're really looking at the intensity of symptoms, the frequency of symptoms, and the pervasiveness of symptoms across life domains. So typically, if you are experiencing anxiety when you go to see your medical professional, for example, that would be a pretty normal, natural human emotional experience. Not necessarily impacting your work on a day-to-day basis, not necessarily impacting your social functioning on a day-to-day basis, but just a normal blip of human emotion. So we're not, when we're talking about mental illness and we're talking about mental health concerns, we're not talking about those ecologically consistent emotional experiences, but rather emotional experiences that are intense, frequent, and really impacting day-to-day functioning. We're also really looking at the duration. So again, if these are symptoms that perhaps you experience for a few days when life is really hard or symptoms are really loud, that's going to be a very different approach coping with those types of experiences compared to more pervasive, intense experiences that are lasting over a series of weeks, months, or even years. And then that final point here is just looking at situational congruence or dissonance. So again, if you're going through a season of heightened symptoms, or you're going through a season of loss within the community, which is something that we've all had to experience, our human emotions are going to be louder, they're going to be more pronounced, and they're going to impact us on a day-to-day basis. However, when they're situationally congruent, a little bit less concerned about whether we would be looking at a diagnosable mental health condition as opposed to normal human emotions. So today we're really wanting to look at both how do we recognize when we cross over that threshold into being concerned about mental health as kind of a diagnostic consideration, as well as getting support for yourself, whether you meet that threshold or not.
So our warning signs or our yellow flashing lights, I might say, are sadness, anger, irritability, fear, nervousness. I wonder, is anxiety an emotion, Karen?
I mean, we could get into splitting hairs. Anxiety is usually kind of a culmination of that fear, that nervousness, the worry combined with some of those somatic symptoms. But many of us think of anxiety and worry as being interchangeable.
Okay. So detachment, disinterested, guilt and shame, rapidly shifting moods. And again, this low motivation, overly excitability, and helplessness and hopelessness.
And so again, for all of these, what we're really wanting to pay attention to is the intensity and the pervasiveness. So if you find me somebody who is diagnosed with a connective tissue disorder who has not experienced sadness, anger, fear, disinterest, guilt, shame, like that's not reasonable. We experience these things. These are really normal experiences. But when you start to string a few of them together, or if you start to string a few of them together for a prolonged period of time, and you notice that they're starting to impact how you function on a day-to-day basis, those are times to start really looking at them as warning lights, more so than just a normal, natural response. So we also want to be paying attention to warning signs around how we're thinking about things. So some of the cognitive patterns that can be concerning or potentially pointing to a possible concern: frequent and excessive worry that's exaggerated, that's unremitting. So again, here I'm not talking about, oh my gosh, this pain just overcame me, and now I'm wondering and worrying, is this going to be a big event? That would be a congruent type of worry or fear that wouldn't necessarily constitute a thinking pattern. However, if you find yourself frequently excessively worrying about every single thing that's happening in your body, that might be something to pay attention to, especially if you're a little bit further along in the diagnosis. I know for many people, those first weeks, months are a time of hypervigilance. But if you find that they're unremitting over time, that's a good opportunity to start paying some attention. Similarly, a sense of impending danger, panic, or doom. And again, my disclaimer is all of these conditions come with very real medical danger and panic that would be situationally appropriate. So it's weighing out along the continuum how significant and how pervasive this is. If it's so pervasive that you're having difficulty being present in the moment and you are exclusively worried about the past or the future and not able to live in the day-to-day moment, those are times to be concerned and start kind of talking to the people in your life that maybe know you a little bit better and can recognize whether these are causing problems. Difficulty with concentration, forgetfulness, these go alongside with a lot of those emotions when anxiety is activated, when depression is higher, concentration and forgetfulness, they go hand in hand. So again, really thinking about patterns and not individual symptoms. Obviously, thoughts of self-harm or suicide, distinguishing between passive suicidal ideation and active suicidal ideation, those are important thresholds. But if you find yourself or somebody that you love is having some of these thoughts of self-harm or suicide, really, really important to take some time to get some help and talk with somebody about what's going on. Shifts in attitude, so a transition from being generally optimistic to a significant shift into pessimism or negativity would be something to pay attention to, as would racing thoughts, ruminative thoughts, or ruminative thoughts are when you are not necessarily thinking quickly, but going from one thought to the next, to the next, to the next, kind of chewing on things over and over again in a way that's not productive, or nightmares. So we have a tendency to take our own brains for at face value. So if we think it, generally speaking, we tend to believe that it's true. And these are good opportunities to slow down and say, okay, this is what I'm thinking about. How helpful is this? How true is this? And if it's not particularly helpful, not particularly true, or again, it's interfering with your day-to-day basis, good opportunity to kind of take pause and look a little bit more carefully at what you're experiencing.
You know what, Karen, may I ask, I was going to present this slide, but would you like to pick out a few of these from your experience and practice that might be very helpful to our viewers?
Sure. So again, I feel like all of these, and I'm not going to read them all off to you, but these are all normal human behaviors that we go through over a lifetime. But when we start noticing extremes, so for example, last night I had some trouble sleeping. I get nervous about presentations. This wasn't, just kind of caught up in my brain a little bit. There were some storms here, so I didn't get a whole lot of sleep last night. That's not necessarily a concerning warning sign. However, if you're having trouble sleeping on repeat over a series of weeks or months, things to pay attention. So you're gonna be hearing me say these same things over and over again. How pervasive is it? How frequent is it? And how much is it impacting your day-to-day life? Appetite disturbance, changes in eating patterns, withdrawing, changes in socializing, shifts in energy, restlessness, agitation, lethargy or psychomotor retardation. That's when you feel really heavy or really slow and you find that you're struggling to just get up and move and do the things that you need to be doing. Sometimes the people around us notice that agitation or that lethargy more than we do. For us, it oftentimes feels situationally congruent, and so we don't recognize that it might be a shift in behavior. So if you've got somebody in your life that's asking questions about this, attempting to slow yourself down, attempting to kind of check your own defensiveness, which we all have, and be curious about what are they maybe seeing that you're not seeing. Doesn't necessarily mean that they're seeing something more accurately than you are, but they're seeing something different than you are. And so it's a chance to say, huh, what's going on with me? What are they seeing? And should I be paying attention to this? Changes in speech patterns, tearfulness, confusion, concentration, weight gain, weight loss, any of these that are on the extreme of one or the other. So go up a couple pounds, go down a couple pounds, that's not particularly worrisome. But if you're dropping weight and dropping weight and dropping weight, and you're not interested in things and you're not having an appetite, although it might be a welcome change, if you can't explain what why it's happening, those are good times to just slow down and bring some curiosity. Diminished interest, not really enjoying things, not getting a lot of zest from your life, irritability or reactivity towards others, muscle tension, increased heart rate. Those are things that I know within the VEDS community we pay a lot of attention to. Many of us take blood pressure on a pretty regular basis. So if you're seeing shifts in those kinds of things, slowing down and asking yourself why would be useful. Breathing more rapidly, sweating, trembling, hypervigilance means being really on guard or on alert for things that might be dangerous. This one again is really tricky because with connective tissue disorders, we are appropriately vigilant. Somebody without a connective tissue disorder who pays as much attention to their body, that might constitute hypervigilance. But with those of us that have, connective tissue disorders, serious risk of complications, we're paying attention to our bodies in a much more attentive way than the average person is. And so taking that with a grain of salt, that what is a shift in baseline for you from normal vigilance to hypervigilance? Shifts in substance use, changing daily responsibilities, avoiding daily responsibilities, poor hygiene. All of these kinds of things can be things that other people might notice before we do, but can be a good indicator that something's going on. Kathy, were there any examples that you had kind of in your practice of times that maybe you saw some of these things show up in clients that they weren't noticing themselves?
Often that hypervigilance to the extreme of everything. So, and I think of these hypersomnia and insomnia and the poor hygiene often go with pajamas. Start to show. So, thank you for presenting that, Karen. It was really insightful.
All right. So I don't want to spend a whole lot of time talking about diagnostic criteria for any of these. So I'm just going to kind of cover some of the diagnoses that we see in chronic health populations. Adjustment disorders are very common. This is a category of conditions where we're seeing generally mood or anxiety symptoms that are exceeding what would be considered normal. Now, I like to put normal in scare quotes because that's not a thing that actually exists in the universe, but we have sort of a threshold of what would be effective coping with major life stressors, and then crossing over that threshold into coping that's maybe causing more day-to-day problems. So the adjustment disorders is classifying those conditions that maybe coping with the condition or coping with a significant medical event is the antecedent to the symptoms. So there's a event, and then there's symptoms, and now the symptoms are causing problems. That's what we see typically with the adjustment disorders. Depressive disorders, most people are pretty familiar with what those are. Major depressive disorder, persistent depressive disorder. Persistent depressive disorder is a condition where you've got a clinically significant low mood, but not as low as a major depressive disorder, but still lower than baseline. So if this is baseline, a persistent depressive disorder is going to hang out, subclinical, but not necessarily with those episodic lows that you would see in a major depressive disorder. Anxiety disorders like generalized anxiety disorder, social phobia, panic disorder. Panic attacks in and of themselves are not a mental health condition. You can have panic attacks with virtually any mental health condition or independent of a mental health condition. So panic disorder is specifically capturing people that experience panic attacks, and the fear of having future panic attacks is causing the disruption in functioning. a panic attack on its own can exist within a profound depression, can exist within a trauma disorder, prolonged grief disorder. So just being thoughtful that the experience of a panic attack, especially a single panic attack in and of itself, is not diagnostically, I was going to say significant. Everything's diagnostically significant, but a single panic attack in and of itself isn't necessarily going to be pointing in the direction of a mental health concern, but could be an indicator that it's a good time to get some help before it escalates and turns into something a little bit more serious. Trauma disorders, so we see a lot of post-traumatic stress disorder or other specified trauma disorders, again, where we're seeing a really significant ongoing impact of a traumatic event. Now, not every person that experiences a traumatic event, either personally or vicariously by, being close to somebody that's experienced a trauma, not every experience of trauma is going to translate into a trauma disorder, but it can. And I think it's important to recognize that that can come from something like a significant medical event or observing a significant medical event among your loved ones, friends, etc. Even within this community, we've got the hard part about loving people with connective tissue disorders is we experience loss at a much higher rate than the average population. And so there's a lot of opportunities for vicarious and secondary trauma that may or may not translate into chronic mental health concerns. There's also a number of concerns associated with the impact of grief, complicated bereavement, traumatic grief, anticipatory grief, which is something that I think a lot of us in our community experience, knowing that there's a decent likelihood of a shortened lifespan for ourselves and the people that we care about, can be very, very difficult. That can be an extremely difficult reality to live with. Which leads me to disenfranchised grief, and that is a grief that others don't necessarily understand. So many of us, when we get our diagnosis or a loved one gets the diagnosis, there's this tremendous amount of grief before anything has actually happened, even though everything has happened, right? Our world's turned sideways. Everything is different. There's a before and there's an after, and our worlds get rocked and things are different. But you don't necessarily see that from the outside. And so it can be difficult to get that understanding from people who don't know what it's like to live with a serious medical condition like VEDS or like Marfan or LDS. An ambiguous loss here, this is just referring to any number of losses that can be death, it can be the loss of mobility, it can be loss of employment changes that we need to make to take care of our health. Kathy, in your kind of nursing career, where did you see the most of this kind of showing up?
Well, I guess that I worked in pediatrics, setting up home care, and often it was from birth where there was a congenital disorder and may have had questionable or varying prognosis of length of life or things, along that line.
Yeah.
So the grief is a big one, and it can start to overshadow a
Mhm.
family.
Yeah, especially when littles are involved.
Yes.
Okay. So whether you or somebody that you care about might be experiencing intense emotions or concerns that would constitute a mental health condition, there are a number of different ways to get support. Some of them are more formal and some of them are less formal. I know one of the beautiful things about these communities is there are a ton of opportunities for social support through Facebook groups, through the conference, through Walks for Victory, peer support groups. Being able to spend time with people who understand can be as priceless as any type of formal medical treatment that you might have. I know the first time I walked into a room with somebody who had VEDS, shout out to Katie Wright, it was at one of the local symposiums, but walked into a room, and for the first time in my life, I was standing in the room with somebody else that had this condition. And there's just this moment of understanding that cannot be shared without it. And so by having this connection to the foundation and having access to support groups, there's a tremendous amount of support that can be found before you even call a therapist or look up a medical professional. Certainly self-help books, music, art, podcasts, etc., can be ways to gain some better understanding about self, gain some more understanding about different life experiences, knowing, of course, that you're going to want to run all of that through your filter of your own lived experience, that there's not a book out there that's going to teach you how to live with or how to love somebody with a connective tissue disorder. But there are a number of different books out there that can address issues such as grief and anxiety and end of life concerns. And there's a lot of beauty to be found in people who have walked before us. And then there is some more structured or professionally led support, whether that's professionally led support groups. There are support groups for people who struggle with anxiety. There are support groups for people that experience trauma, individual therapy or counseling. Psychiatry is referencing medical professionals that prescribe psychotropic medications to address clinically significant depression and anxiety. And those would be good places to start if you're not quite sure, if you're questioning, is this normal? Is this something that would benefit from a little bit more structured professional support? Those are opportunities to kind of get some of those questions answered and get a better footing over what might be next. I think sometimes people feel like if you walk in and call a therapist, that's it. You're going to see a therapist forever. And that's really not, that's not how it works. And it's certainly not always the case. It can be simply getting, having a few sessions to get some support from somebody who's not in the mix of it with you can be incredibly eye-opening. And for some people, that can be enough to get some coping skills to kind of turn things around. So one of the questions that I often get, both in my personal life and in my professional life is, well, holy cats, where do I even begin? How do I find a therapist? It feels like this impossible, overwhelming task. And it can be. It can be, because finding a provider that understands you and finding a provider that you connect with doesn't always just happen right out the gate. So I think you can speed things along by getting referrals from friends and doctors, reading reviews about different clinicians. Most clinicians are going to have a bio, which, as a professional that has a bio, they're probably the worst thing in the world to write. And I feel like mine doesn't describe me at all, but it's a place to start. It's a place to get a little bit of the voice of the person that you'd be sitting in a room with. Asking members of the community within the Facebook group and other connections to get experiences if they've met somebody who knows something about chronic health concerns or with ambiguous loss. That can be a really good opportunity to start. We run into issues with licensure and being able to provide services across state boundaries. So sometimes those types of referrals can be a bit challenging, but it's still a good opportunity to start, especially if you've got somebody in your geographical community that knows somebody who knows a little something about Marfan's or beds. A common virtual resource for finding providers or Psychology Today. There's a Find a Therapist link and Good Therapy as well. So a lot of clinicians that work in a private practice will have personal information about their approach to therapy, their educational background, areas of specialty. So those can be places where you can narrow things down. And I'll talk a little more about some things to pay attention to if you're using one of those kind of virtual search networks. You can also certainly find mental health professionals in community clinics, medical clinics and hospitals, universities. My least recommend option is to call that number on the back of your insurance card, because they're just going to throw a bunch of names out at you. However, if you can get a few names of people that are nearby, you can use that as a starting point to look at some of those bios and get a little bit better experience or better voice of the person that you might be meeting with. And then the Marfan Foundation is another great avenue. There's Ask a Question on the homepage there of the website, but also support groups, people who have gone through what you've gone through. will oftentimes have good guidance about places that they found support or places that they found helpful. So how do you find the right person? The number one piece of advice that I give to people who are asking, how can I find the right person for me, is you've got to actually talk to somebody, interview them, have a conversation with the therapist before you decide. Research shows us that the number one indicator of change in therapy is the quality of the relationship, the quality of the rapport between client and clinician. So you might have the most well-trained, world-renowned provider in medical trauma, but if you don't click, it's probably not going to be terribly helpful. And that element of clicking, you really can't get until you've had a conversation with somebody. Some people will describe it as kind of like speed dating, right? Like you spend 5-10 minutes talking with somebody and you can weed out half of the duds without even needing to go any further. And I say that kind of tongue in cheek because there can be wonderful clinicians that aren't wonderful for you. And professionals know what that's like. Professionals know what that means and will not take it personally if you have a conversation and come back to them and say, I'm not sure that we're going to be the right fit. Do you have anybody else in mind that has a similar background? And any good clinician is going to hear that and say, thank you for telling me. Let me give you some other names of people that might be a better fit for you. You can also pay attention to licensure and educational background within the mental health field. There are master's level clinicians, doctoral level clinicians. There's something to be said for paying attention to that, but I think there's a lot that can be made up with a lot of ground that can be made up through specialty training. So I wouldn't get terribly hung up on whether you're looking at a master's level or a doctoral level clinician, but really paying attention to what their background is, what their training is outside of the degree itself. Beyond therapist-client fit, the next most important way to kind of cull through all of the providers out there is to start looking at specialties that are relevant to you. So finding somebody that's familiar with a chronic health concern or chronic caregiving fatigue, which I'm realizing right now I should have included on here, but I didn't. But caregiving is a very different kind of weight, a very different kind of pressure than somebody simply living with a chronic health concern. And so providers that are very well educated in chronic health concerns may or may not have that same background or specialty in caregiver burnout, caregiver fatigue. So really checking in with yourself about what are the main concerns that are relevant for you and what's going to be most helpful. Certainly specific training in trauma modalities, grief and loss, those are other good ways to sort of weed in and weed out the providers that are going to be the best fit for you. A quick note about therapy versus psychiatry. Psychiatry is the profession within mental health where we're prescribing psychotropic medications. They are generally their own professional independent from therapy. So if somebody is diagnosed with a significant mental health concern, they're usually going to have a therapist and a psychiatrist. Psychiatrists are very well educated in the chemistry of how to support psychological well-being and rebalancing, but they don't typically have a lot of time to spend with you. So if you're considering medication as an option, I would also very much always encourage considering therapy as a conjunction, in conjunction with psychiatry. And in case I haven't mentioned it thoroughly enough, really making sure that you have that personal connection, goodness of fit, or chemistry. It can feel a little bit like dating or kind of trying out friends at the beginning. This isn't a person that needs to feel like a good friend, but it is a person that you need to feel comfortable sitting in the room with, being vulnerable and knowing that they're going to hear you and they're going to seek to understand. Some other considerations to think about are whether in-person or virtual therapy might be more helpful for you. I do both in my own practice and I see advantages and disadvantages of each of those. So checking in with yourself about whether one or the other of those feels more appealing. There's a whole bunch of jargon about different approaches to therapy, and I could talk for 3 hours about these alone, but checking in with yourself about what kinds of work, what kinds of interventions, what kinds of conversations you might feel more comfortable having in therapy, and you can do some research on that as well. But common approaches to therapy would be psychodynamic, humanist, cognitive behavioral therapy, narrative, acceptance, commitment therapy, play therapy for young kids. And all of these are evidence-based approaches. They are all effective at treating these types of concerns, but there are individual differences in terms of what feels good to each individual clinician and what feels good to each individual client. So those would be good questions to ask at that first therapist interview that I'm encouraging is, how do you approach therapy? How do you describe your work to other people so that you can begin to get a feel for whether that's something that feels congruent with your own needs or not. One special word about trauma interventions, because trauma is so common, medical trauma with those of us with connective tissue disorders, there's a number of different trauma-specific interventions, EMDR, accelerated resolution therapy, cognitive processing therapy, trauma-informed CBT. All of these are nuanced ways of addressing trauma, but if you are wanting to specifically work on trauma or post-traumatic stress disorder, becoming an educated consumer of some of these different modalities can also help narrow your search down once you know a little bit more about what they are and which is most appealing to you. All right. How do we
Karen,
do on time?
we're doing well, and I have a couple of things that come to my mind as you've shared such a beautiful, wide, broad list of resources and thoughts. Was that I know when after I went through some loss, that losing parents in 2008, and then my brother and sister that both had Marfan's in 11, and I started having panic attacks, that I decided I needed to resign, to stop, to deal with the grief. And I set up both private, personal, one-on-one counseling and a group support, grief share. And I just found that the two-prong approach, and I was fortunate that there was a new grief share starting that like 2 weeks after I had left work and to deal and had resolved to take care of me. And I guess I just want to encourage everyone listening that take care of yourself. You're important. You need to take the oxygen first. You know? So do that. And part of the benefit I found in the support group was that I realized I wasn't crazy, that it was just part of grief and of loss, you know. So being around others that were experiencing the same feelings, the trouble thinking, sometimes word finding, a little bit of the anxiety. That was just so good to know that I wasn't the only one and I wasn't alone. Again, I just want to encourage you, my friends, you are not alone.
So, hi, I'm Andrea Friedman with the Marfan Foundation staff, and I just want to thank you both so much for your very thorough and informative presentation. I hope that people have really heard those words and really understood that there are so many resources out there to help. And I tried to put some of them in the chat, so please make sure you check that out. We have some questions in the Q&A. If I could just read those and you could respond. The first question is about medication versus CBD. Are there any recommendations that you have? They said, as a patient, I already take a ton of medications and I'm loath to add more.
Yeah, well, I've got my own thoughts. Kathy, with your medical background, do you want to field that one first?
Not really. I've personally tried the CBD, but I didn't find that it helped myself. That but it's something it's an available resource. It seems like a new resource, you know, that we didn't have 10 years ago, and that everybody reacts differently. So don't be afraid of it. Try.
Yeah, I think CBD in particular, I've had really good experience within my practice of people using that to quiet some of the anxiety more so than mood concerns. So I would encourage people to be thoughtful about what you're wanting that to do. And my big disclaimer is always talk to your medical professional first, right? Anytime we're using supplements, there's some limitations in terms of quality control and testing and, consistency of dosages and things like that. So always be thoughtful and in communication with your medical team about those concerns. But I think if you're somebody who's dealing with anxiety, CBD is it's a relatively innocuous place to start and see if it helps, see if it makes a difference. Comparable, I would say, with like melatonin, if you're struggling with insomnia or sleep disturbance, starting with something a little bit more natural like melatonin can be a really good option. I would, to the note about being loath to add something else to your medication regime, I can really understand and relate to that. And in the same way that many of us pursue better living through chemistry for our physical health, there's a lot to be said for better living through chemistry in our mental health as well. So yes, getting layers upon layers upon layers of medication can feel disheartening and can certainly make care more complicated. If the symptoms are impacting daily functioning to the point that you're considering whether it's a good option, it can be worth trying. And knowing that it doesn't mean that you're committing to using this medication forever. Many times people will use medication for a particularly difficult season, and then we'll find a lifting or an improvement of symptoms and can come off either for a while or altogether. So, I mean, the short answer is it can absolutely be effective, but do so in conjunction with your medical team.
Great. Thank you very much for that response. The next question is from somebody, and I'm going to probably mispronounce this, so I apologize. I've heard the expression Damocles syndrome in relation to cancer patients in remission, references the sort of Damocles, a fear of something happening to you, but almost never in relation to Marfan syndrome and related conditions. Why not?
My very strong suspicion, this is pure speculation at this point, is that there's just not that many of us. Many of these, when we put names on things, typically what we're doing is we're saying we see enough of a pattern, especially within the mental health field, we see enough of a pattern of people with this constellation of symptoms that we can call it something and we can look at it and we can study it and we can treat it within the definition that we're using. Our communities are so small that whenever we get one standard deviation away from the norm, it becomes harder and harder to study those constellations of symptoms because we don't have a big enough sample size. So that notion of being afraid of something happening again, I can speak anecdotally as being very widely and very broadly experienced. Putting a name to it requires a bit more research and a bit more funding, which is, the uphill battle that we face with everything.
Right. Kathy, did you want to add to that or?
No, I don't. I'm not for, I certainly experienced that, with being 66 and having Marfan's, that there's been different events that have happened that I found them with choking. And in our Marfan support group for 50 and older, it was so reassuring to hear I wasn't the only person. It wasn't something in my head or something. I mean, even though that it doesn't make it any difference, but it did make a difference. It really made a difference knowing that it's something that is just part of life. But what also made a difference, because I was afraid to eat alone after a couple of choking episodes that my mind had went to, gosh, is this the last time that I'm here? The last meal I eat, that I went through EMDR, which is that like retraining of all those emotions of that happened. And it is just given me back life where when my husband's not here, I can have dinner by myself and enjoy it and eat. And sometimes when those big vitamins get stuck, I don't immediately revert back to that trauma. So I would just say, I think it is something that's very prevalent in our communities, but there is help to take off the edges of that. And one of those, if you're experiencing that, you might want to look into something like EMDR. It really has changed the way that I don't panic if something gets stuck. And I have my life back to go out to a restaurant again, to eat. So I was having that weight loss because I was afraid to eat because of the choking and the response from the trauma. So, it may seem like something very small. That's what I want to emphasize. It affects our quality of life there, and being in a community, you can, it helps you either to find resources or to find that support that you're not alone.
Thank you. That's such an important reminder that you don't have to always just sort of accept that these things are always going to be there. There often are ways to find help and improve your quality of life. So I'm so glad you were able to find that, and hopefully that inspires others to seek the help that that they could really use, and you really deserve it. So definitely look for different ways to help. Thank you. We have one more question so far. And before I read that, I'll just remind people, if they do have any questions, please submit it in the Q&A, and you can do it anonymously. So the next and the last question so far is, any recommendations with respect to managing or overcoming the cost of getting help?
Oh man, a lot of that is jurisdiction dependent. So like here in Minnesota, we have a lot of resources for people who have financial barriers to therapy. We've got a number of walk-in clinics, a lot of our universities, and I imagine this is pretty widespread throughout the country. A lot of universities that have training programs for clinicians. So part of the training is whether you're a master's level clinician or a doctoral level clinician. You get your educational component, and part of that educational component is actually learning how to do the job. So practicum, internships, and then a number of years post-grad before you're independently licensed. So a lot of universities offer pro bono resources, and those are opportunities that you'd be generally working with a clinician who is not as highly trained, but they are affordable, oftentimes free, and those individuals are under supervision. So they're very much in that learning stage of their training, where there's a lot of eagerness, a lot of energy, a lot of heart, a lot of soul. I train a lot of young clinicians, and there's a beauty in being a beginner in this field that just can't be replicated. So those would be good universal resources. There's been a lot of advertising, if you will, about some of the what's the word that I'm reaching for? Like subscription-based services. There's certainly value to be had in some of those services. There is my disclaimer with some of those, like BetterHelp, and some of those is to just really be thoughtful about who the individual provider is that you're working with, and thinking about what kind of long-term care you would need. But the cost is certainly a barrier. Even with insurance, copays add up over time. Those are conversations, though, too, that you can have with your clinician. I have conversations all of the time about, I'd really like to see, somebody would really like to meet weekly and simply can't afford it. And so we make adjustments, and we make it work as best we can. So I would encourage you not to let the financial barrier be prohibitive, but rather recognize that it is a real burden and think about ways to work with it before completely giving up and saying it's not accessible.
I guess two areas I think of is, we can get kind of on a narrow road of, of this standard way is you go see somebody. But I've seen so many more opportunities for virtual. If you have insurance, I would look into seeing, excuse me, with our insurance for, there was virtual appointments for behavioral health that were free or no copay versus going in someplace. And I would just encourage you to, if you have insurance, really look at the broadness of it. Look at every opportunity that it has, first of all. And and sometimes maybe if your concern is medication, that I know I've just come across in the last couple of weeks, an organization that was started by, I think it's Mark Cuban. I can't think of the name of the organization, but if you Googled Mark Cuban, like people that have, a lot of our medications, some of the heart, the losartan, the beta blockers, they've all been around. The generics are less than, I'm paying $2 instead of the minimum, or instead of the, other co-payment, because they're so cheap. But it may be that for some of the mental health medications, it may be more and more than you can do. I would recommend you Googling Mark Cuban medication. I can't remember the name of it. I don't know how to do it on my computer while we're in Zoom. So if somebody does, that for his organization, that I have a friend with Alzheimer's, that her medication is going to be like $500 a month, not on the formulary. And yet it's going to be like $30 through this organization. So talk to people, right? Aaron, talk to people, and Andrea, and maybe our help desk would have some ideas.
Yeah, I was gonna say, the important thing is not to assume and give up, that, keep trying, and usually there are some resources, and at the very least, it's not individual therapy, but we have our monthly support groups, and so that's one way to at least not feel isolated, and be able to talk about some things that others might be sharing, and so certainly not to take the place of therapy, but just another option. It's all about finding different tools in your toolbox, and there are many. And one person mentioned in the chat that employee assistance programs are also another good resource if you have access to those. Usually you're able to get some, a small number of sessions, either free or discounted. So that could also help you.
So if you're being prescribed some medications that you can't afford, it is the Cost Plus Drug Company, or even Mark Cuban Cost Plus Drug Therapy. It's kind of a surprise sometimes, isn't it, when you go to the pharmacy with a little slip and they give you some something that's like kind of.
Absolutely. I don't see any more questions in the Q&A or in chat. Let me just double check one more time. No, well, I will remind everyone that if you do have any questions that you think of once the session is over, because that always happens, please reach out to our Help and Resource Center, as everyone has been saying, at marfan.org/help, and the link is in the chat. It's also on our website, but our Help and Resource Center has been incredible in terms of helping to find resources, connections in the community, and really connecting you with some experts locally, nationally, globally. So please consider that a resource. Also, visit our website for information about all of our 18 different support groups right now, and there's definitely something for everyone. So please check out that resource as well if you're not already connected. And do you have any closing words before we end, either Karen or Kathy?
I was thinking about the issue. I don't know if any of our participants are caregivers, but sometimes, their adult children have, we as adults, we're single, divorced, whatever, widowed, and need the help from family members or friends. And so if any of those family members or friends or caregivers, another resource for caregivers is AARP. And that might sound like that's just old people, but they have a lot of resources under caregivers. And it just, if you're looking for resources, that's another one. Right.
Well,
Absolutely.
and I
Thank
just
you.
wanna thank everybody for being here. We tend to pay a lot of attention to our physical symptoms with these conditions. They tend to be very loud, and we get mobilized very early on after diagnosis to address the medical complications with our conditions, as we should. And what I've noticed as being part of this community is that the emotional toll builds up over time. It certainly can, and that to take care of ourselves and to be emotionally well is a gift that we can all give to ourselves and to our loved ones. And so whether it's through therapy or self-help or the support groups, just continuing to really value and honor how hard this is, and to avail yourself of the resources that are out there.
Thank you. What wonderful words to end by. And just a reminder to everyone, we have been recording this session. So if you weren't able to capture certain things or want a reminder of what our incredible speakers shared, it will be on YouTube sometime in the very near future. And again, stay in touch, take care of your mental health, and be well. All right. Thank you, everybody.